Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Ovarcome, and today we are joined by an esteemed guest, Dr. Brian Slomovitz. So Dr. Slomovitz is the Director of Gynecologic Oncology and co-chair of the Cancer Research Committee at Mount Sinai Medical Center, and he's also on the board of directors and leads the Uterine Cancer Foundation research at the GOG Foundation. So he's considered one of the top global experts in the field of gynecologic oncology and is known for his passion and commitment to our overcomers worldwide. So we have a lot to chat with Dr. Slomovitz today about not only the entire spectrum of ovarian cancer treatment, including surgical advances being made in this space, but also his vision for a world without ovarian cancer. So join us for the next 45 minutes to an hour as we chat with Dr. Slomovitz, and have your favorite beverage ready. I have mine, and let's chat with him about all things ovarian cancer. And if you have any questions as we go along, please type in the comment sections below and we will get it addressed post the discussion. So with that, a huge welcome to you, Dr. Slomovitz, to this episode of Connect Over Coffee. Always an honor to have someone like you join us.
Thank you very much to have me today, and I'm honored and humbled to be given the opportunity to meet with you today. And this is my passion. This is what I want. We want to try to get rid of these cancers. They're horrible. So thank you for allowing me to help spread the word about prevention and treatment and ways to beat ovarian cancer.
Thank you. So, Dr. Slomovitz, we have a lot of questions for you, but I'll start here because while doing my research on you, I came up with this, this sentence, and I stalled there for a second. I wanted you to talk about it a little more. You said somewhere that your passion is repairing the world one patient at a time. Tell us more about this profound statement.
Yeah, no, when I really have two jobs, right? I take care of patients on a day-to-day level and, meet with them, their family, their friends, and come up with ways to treat them. Mm-hmm. And I always tell patients, when I'm in the room with them, there is no one more important. There's nothing else that we're focusing on except figuring out ways to beat the cancer in that one particular individual. Sometimes we use standard of care. Sometimes we think out of the box and come up with a better treatment plan. Sometimes we put clinical trials, but when I'm meeting with a patient one-on-one, the focus, what we're doing is treating that patient. And if we treat that patient, we're not just treating one individual, we're treating all the patients in the room, the people in the room, we're treating their loved ones and figuring out a way to, to not give them one more holiday season, to give them many more holiday seasons, many more weekends, many more graduations. And then my second job is to come up with the right treatment protocols and the treatments to study them in studies that could have hundreds and hundreds of patients to see what we can do to change the bar, to come up with more treatment options, but also to improve the ones that we have. So, I feel myself very fortunate. I think I have the best job in the world. That's what I meant, really, just two different focuses, the one individual and the disease survivors at large.
And that two things that you focus on makes it one complete journey for our overcomers. So thank you so much for sharing that with us. So you have published papers and presented on a variety of topics, but tell us about cancer in pregnancy. What are the implications, and what should our overcomers know that are of childbearing age about this?
That's a great question. It's something that we deal with quite often. It's not only cancer in pregnancy, but it's also cancer in a woman who is either trying to get pregnant or is looking forward to get pregnant sometime in the near future. When we see ovarian cancer in women who are later on in life or who are not having more children, the surgery of choice is quite easy. We not only get rid of all the cancer that's there to the best of our ability, but we do a hysterectomy, remove the tubes and ovaries. Now, in younger patients, whether they're pregnant or not, the goal is to maintain the ability to have children. So there we're focusing on ovarian preservation, the ovar that's not involved, obviously uterine preservation, different, preventing some of the cytotoxic chemotherapies that could harm the ability to become pregnant in the future, that could cause ovarian failure. and really figure out ways to help them and maintain their goals. Oftentimes we have to have a difficult conversation because occasionally maintaining that ability to have children could in fact make it a little bit more difficult to treat. But my job isn't to put myself into their shoes. My job is to talk to my patients about different treatment options. Sometimes we do egg retrievals, embryo retrieval, embryo freezing, as ways to maintain the ability to have their own children. But ultimately, it's up to the patient, and I can't. It's not up to me to be paternalistic and tell them how important pregnancy is or not. It's up to me to give them their options and come up with those treatment choices.
Of course. Thank you. So, what is lymph node mapping in ovarian cancer? I saw that you specialize in this, and tell us, why is it done, and how long does it take, and which type of patients benefit the most from it, and how is the information used in the overall treatment and well-being of a patient?
Sure. So one of the nice things about lymph node mapping in all gynecologic cancers, it actually decreases the morbidity of the procedure. It makes it much less invasive than to remove all the lymph nodes and things like that. The in ovarian cancer, in ovarian cancer, we're still investigating it. Now we do have lymph node sampling, and we do have lymph node evaluations in vulvar cancer, uterine cancer, and cervical cancer, which has really become the standard of care. Now, if we could do the proper investigations in ovarian cancer about sentinel nodes, rather than making huge incisions, rather than removing all the nodes, which has its own risk of morbidities associated with it, we could really focus on the one lymph node. Now, if that's involved, then we know it's higher stage disease, and we do the treatment planning based on that. If it's not involved, we know that the likelihood is that it won't involve any of the other lymph nodes. I think it's going to be a little bit more difficult in ovarian cancer. I do, but it is something that we should work towards, just like we have in vulvar, endometrial, and cervix cancer, to help change the standard of care.
So I'm just curious, as you were talking, for all the other cancers that you talked about, right, for a second, how has it transformed the care for these kinds of cancers, even though it's not ovarian, but I'm just curious to know regardless.
Obviously these are all important women's health issues. In vulvar cancer, we used to do big excisions, and women would suffer from groin infections, groin erythema, leg swelling, wound breakdown. Now we can make a little 2-centimeter incision, take out one lymph node on either side of the right and the left groin, and based on the results of that, determine what their treatments are. Endometrial cancer, we used to do lymph node dissections all the way up to the abdomen, past the kidneys. Now, because we're doing sentinel nodes, we don't have to do that. And we could decrease the time of the surgery, decrease the blood loss of the surgery, and make the healing a lot more quickly. Same philosophy in cervical cancer patients.
And so for ovarian, what are the challenges that you think that we are still not there yet, as you mentioned, but what are the main challenges?
The main challenge with ovarian cancer is the lymph node network in the pelvis is a little bit more common for a little bit more, complex.
Yeah.
For the ovaries. So it's a much more complicated network to predict which. Maybe the sentinel node means the gatekeeper node, the one node that if it's involved, others can be. If it's not involved, it doesn't get past the gate. Because of the more complex network on the ovaries, it's not going to be impossible, but it is an option that we could hopefully work towards making it standard of care in the future.
That would be wonderful. Thank you for sharing that. So you also seem to be interested and have an interest in robotic surgery, right? So tell us about the role of robotic surgery in ovarian cancer. What advances have been made, and how and when are they used, and anything you could share, really?
Yeah, so robotic surgery is a great approach to surgery. It is associated with less blood loss, less pain postoperatively, shorter hospital stays. Now, in ovarian cancer, similarly to the lymph node mapping, it's much more established in endometrial cancer. We established that actually robotic surgery is not good for cervical cancer. In ovarian cancer, there are some well-accepted procedures that we can do with robotic surgery. Removing an ovarian mass to see if, in fact, it's cancer or not. And then if it's limited to the ovary, we could do robotic staging to evaluate the lymph nodes and to take out what we call as a fatty drape in the abdomen, the omentum. But we're not sure yet, and this is really where we're changing the standard of care on a daily basis. What we're not sure yet is whether or not in patients who receive chemotherapy for advanced disease, or if they just start with advanced disease, the role of robotic surgery. So actually, there's going to be a national study soon. It's led out of MD Anderson. It's called the LANS trial, evaluating whether we could do robotic surgery in these patients or open procedures. So that's an example of, yes, it's standard in the first stage, and we're going to see if we can push it into later stages. But again, it's a really cool technology which results in better patient outcomes as far as hospital stay, blood loss, and pain.
Yeah, speaking of the LANS trial, we actually got approached by the Anderson research team that are working on this particular trial to kind of get engaged and involved with it. So yes, I mean, it sounds very promising.
I like game changers. This may be a game changer.
Right, absolutely. So stay tuned for more on that. As the more information comes out of LANS, we'll share with you all. So there's some recent press and conversations, and this is a great segue. We were talking about LANS right now. So conversations around open surgery versus the minimally invasive surgery for ovarian cancer, right? So which one, in your opinion, would you say is more efficient and superior for our overcomers, and why? And who would be the ideal candidates for one versus the other?
Yeah, so as a traditionalist, right now, open surgery is still, for advanced stage disease, is still the standard of care. As I mentioned, I'm a big believer in clinical trials. Okay, and determining if there could be a difference. But right now, until we change the standard in patients with advanced disease, I'd prefer an open incision. Mm-hmm. While there are some physicians who don't do that, who go forward with robotic surgery, we really need to look at the long-term outcome of these studies to see if, in fact, it is safer. The perfect example there is in cervical cancer. For years and years and years, we thought that minimally invasive surgery was at least the same, if not better. Pedro Ramirez at the Anderson did a study of that and found that it was actually worse. So we've left it with open surgery for cervical cancer, for radical hysterectomies. And we'll see what it shows in ovarian cancer, but it's definitely worthy of investigation. And again, my stage 1 patients, I prefer to do robotic surgery.
So it just depends on the stage of the patient and the disease state and I guess the overall health of the patient as well, right?
Right. In advanced stage patients, we really need to make sure we get out all the tumor. And until we could demonstrate in the population at large that robotic surgery can do that, it'll still be under investigation.
Thank you. So this is fairly still new, that we are recently out of ASCO, right? I mean, it's been a few weeks, but it's fairly still recent. So which studies or breakthroughs in ovarian cancer from ASCO would you like to share with our audience?
Yeah, I think the main study from ASCO, which is really, a game changer, is there's something called the Athena trial. Mm-hmm. Now, the Athena trial is evaluation of another PARP inhibitor looking in the first-line setting. So in patients newly diagnosed with ovarian cancer, whether we could give what we call a maintenance therapy with a drug called rucaparib, right, to see if we can keep the disease away longer. Now, this was a study sponsored by the GOG and by NGOT. Brad Monk was the lead author. What we found is patients treated with rucaparib, the disease stayed away longer. Okay, so particularly we saw the difference much more in patients with BRCA, BRCA mutations, and in patients who have something called homologous repair deficiency, and in all comers, really, in all coming patients. So what this confirms is that maintenance therapy works in PARP, using PARP inhibitors, rucaparib in particular, in this setting. There was another trial similar to this with the PARP
Dr.
inhibitor.
Slomovitz, can I go back to the rucaparib
Of course.
mention? So one question was that you said that the disease stayed away longer. So what is the longer? What is the duration that was it significant? Was it, I would like to just kind of focus on that for a second.
Yeah, sure. So the first thing we do is when we're designing a trial, right? When we're designing the trial, we have to work with our statisticians, and we determine whether or not, we come up with numbers that we need to meet in order to numbers we need to meet in order to say it's statistically significant.
Right.
So number one, it was statistically significant. All right, and then when we look at the numbers in the entire population, and I have little notes here because I'm to make sure I'm giving you the right numbers. The median PFS in the treatment arm, PFS being progression-free survival, was 20 months compared to 9 months, doubling it in patients who did not receive rucaparib.
Mm-hmm.
Obviously, the difference was greater in patients with PARP with BRCA mutations or HRD, but I think that the fact that the overall survival was progression-free survival was improved in the entire population. This is a game changer.
Absolutely,
it is. We did a similar study in niraparib, and that also showed that we could increase the progression-free survival in giving the niraparib PARP inhibitor. So we have options to give. There's been some non-statistical opinions that are coming out lately about PARP inhibitors and overall survival. I'm a big believer that women with ovarian cancer at some point along the course of their disease deserve a PARP inhibitor. And I think that's been really used to help prevent, to help people live longer from ovarian cancer.
So two things. It seemed like with this particular trial, it seemed like progression-free survival, as you said, almost doubled, which is pretty significant. And then you also kind of mentioned that all ovarian cancer patients should at some point in their journey be treated with PARP. So does this include even the non-BRCA carriers or?
Yeah, so that's what.
Yeah.
In this study and in the PRIMA study, so rucaparib and niraparib, the way we refer to it in our field is biomarker negative. Mm-hmm. So in those patients who don't have a BRCA mutation, those patients don't have what we call homologous repair deficiency, which is sort of like a BRCA-like characteristic of the tumor. It works in those patients, but it also works in all comers. So they don't need to have one of those biomarkers in order to determine who gets the treatment. So again, all patients with ovarian cancer, I think, and if they don't get it in the first line, because there are some other options there, they should get it in the second line treatment. But it is, in my opinion, it's part of the reason why women with ovarian cancer are definitely living longer, which is ultimately our goal.
That's wonderful. And so, just off the top of your head, what percentage of the patients are actually getting the PARP? And the overall
right now, when a study comes out, then our job is to really help to disseminate the information. Ovarian cancer, while I see it a lot, and a lot of us see it a lot, there are also a lot of physicians around the country who don't see it as much. Mm-hmm. We know that physicians who don't see it as much, we don't want to take away their patients because they're smart physicians and they do a great job, but we need to educate them on the PARP inhibitors in order to not, to use, number one, use them, and then to give the appropriate doses for efficacy and to limit the side effects. So now that this data has come out, and with the PRIMA data, we need to do a better job in educating our patients. So right now we're about 40% of uptake. We need to increase that in order to make sure that most women who suffer from this disease can reap the benefits of this type of treatment.
So sounds like there's a lot of room for improvement. And I asked this question because we have talked to our overcomers directly about this, and several have told us that they have never been treated with PARP inhibitors. So that's why I was just curious to understand where we stand in terms of the percentage. So thank you for sharing that. So immunotherapy, that's another very big, always a point of interest when it comes to ovarian cancer. We know that we have not made as much stride in immunotherapy, but yet there are many open studies or trials are about to be released or go into human clinical trial kind of studies in immunotherapy in ovarian cancer that we are constantly reading about. So what is your thought, or what is your guidance to our overcomers if you were to talk about the challenges of this treatment and things that our overcomers should be aware of when it comes to immunotherapy? And also if you could just share some advances in this space.
Yeah, that's a great question. First of all, the trial that I mentioned, the Athena trial, we actually, half of the results were reported. The second half of the study is looking at immunotherapy. Okay. Now, in general, the way immunotherapy works, it stimulates the body's immune system to look throughout the body to see what doesn't belong, to recognize what we call self versus non-self. If we stimulate the immune system and the body can't determine, everything looks like something should be in the body, immunotherapy doesn't work. So the difference, another way of calling it is hot tumors. The body recognizes them as something that shouldn't be there. Cold tumors, they hide from the body's immune system. Now, in the cancers that we treat, endometrial cancer has a potential to be a quote unquote hot tumor. And what we've learned is all women with endometrial cancer at some point deserve an immunotherapy in order to help manage their disease before they would get sick from their cancer. Same in cervical cancer. Immunotherapy works. There's a lot, they're considered hot tumors. Now, ovarian cancer is not the case. The ovarian cancer can evade the body's immune system better than cervical, endometrial cancer, melanomas, non-small cell lung cancers. So what we're working on is figuring out ways to turn these quote unquote cold tumors hot, to figure out what we can do to help increase the likelihood that immunotherapies are work in the body to help get rid of the cancer. Thus far, we've had 3 prospective randomized trials, which shows it hasn't worked. It doesn't mean we're giving up, but we're really trying to, again, turn these cold tumors hot to figure out better ways to treat the disease. And we're not done. We're not done investigating it. So we're going to do our best to investigate it, to figure out what we need to do, and hopefully to come up with more treatment options. But it's definitely not ready for prime time yet.
Okay. Thank you. And that is why we keep doing the research, so that we can get to that point where we want to be. So
Exactly.
yeah, thank you for sharing that. So I know that you're running several endometrial trials via GOG. So there's some latest news and articles that I was reading about the linkages between ovarian cancer and endometriosis, right? So can you talk to us a little more about that? And also, what are the chances that a primary endometrial cancer can lead to a secondary ovarian cancer and vice versa?
These are great questions. You've really done well in preparing for our meeting, so thank you for that. Endometriosis is when there's normal appearing endometrial glands that grows in abnormal places. And however they get there, they get into the pelvis, and they could cause pain with their periods, discomfort, things like that. Occasionally, rarely, but it does happen, endometriosis can convert into a cancer. When we see that, they're oftentimes landing on the ovary or landing on different structures in the pelvis, and they're quite difficult to treat, because the surgery for endometriosis without cancer can be very difficult because it sort of sticks to things, and it's tough to dissect tumors away. And surgery for the cancer actually makes it worse. As mentioned, fortunately, it doesn't happen. But when we see it, we treat it like an ovarian cancer, because it pretty much is an ovarian cancer. We treat it aggressively and give it the chemotherapy associated for ovarian cancer. Now, as far as how often does endometriosis or endometrial cancers, migrate to the ovaries, we can see it actually 10 to 15% of the time. The difficulty there is to determine, is it a endometrial cancer that's spread? And that would make it, instead of stage 1 disease, it makes it stage 3A disease. And those patients most likely need either radiation or chemotherapy. Or is it a primary ovarian cancer, and the person has 2 cancers, what we call in medicine synchronous primaries? Mm-hmm. The advantage of synchronous primaries, 2 stage 1 cancers are easier to treat than a stage 3 cancer. So, we need to do molecular profiling. We need to do aggressive genetic evaluation to see if it's 1 or 2 different tumors. We're getting better at it. And I could say that patients with this disease are living longer. That's
a great clarification. Thank you, Dr. Slomovitz. So just to delve a little deeper on that question, we talked about endometriosis, which is benign, right? For those patients that do not, at the point of presentation, they are just endometriosis, not endometrial cancer. Do they eventually, or can they eventually develop ovarian from that, or there is no established evidence as yet on that?
They can. Usually in my practice, what I do is a woman who presents with an endometriosis on the ovary, that's also known as an endometrioma. If it's symptomatic and growing, I like to take it out because I really want to make sure that it's not cancer. And here's an example of I could use robotic surgery. So I want to take it out. Fortunately, most of the time it's not cancerous. And once I did one surgery and I could prove that it's not cancerous, I try to be as conservative as I can and not operate anymore for these patients because we know it's benign and we know it's most likely it's not going to come back. But unfortunately, sometimes when I do these surgeries, occasionally we'll see a cancer or a precancer, something called a borderline tumor, and then we have to manage them as the cancer. Either different strategies that I discussed earlier for fertility preservation or definitive surgery with hysterectomy and removal of both tubes and ovaries.
Thank you. So just a curious question on the biomarker-driven therapy. What is that?
Yeah, no, that's a great question. I sort of described it a little bit earlier for BRCA and for homologous repair deficiency. But there's also a whole slew of other biomarkers. Let me tell you, for there's a tumor called a low-grade serous ovarian cancer. It sort of plays differently than high-grade serous ovarian cancer. It's a slower, indolent course. What we're learning is there's some biomarkers, something called a MEK pathway, and there's MEK inhibitors which help to offer a biomarker-driven therapy to help stop the growth of these tumors. There's also newer therapies that we're investigating, and actually I have a trial that I'm running with Dave Gershenson over at MD Anderson. It's a national trial looking at something called a CDK4/6 inhibitor with a hormonal therapy. The biomarker that these tumors show is similar to breast cancer. So that's a breast cancer treatment, and we're incorporating that over to ovarian cancer. So we like to do what we call next-gen sequencing, next-generation sequencing on our ovarian cancers. And if we pick up a positive signal, also known as a targetable mutation, and we have an actual drug for that mutation, then we initiate this biomarker-driven therapy.
Okay, thank you. So recent findings suggest that progression-free and overall survival are enhanced both with the use of BEV plus first-line chemotherapy in ovarian cancer, right? Can you tell us more about this finding and what our overcomers should be aware of?
Yeah, sure. So, we talked about this what we call this maintenance therapy. And when there's maintenance therapy, that's giving additional therapy after the primary chemotherapy. What people don't realize, it's not a new concept. We've been studying maintenance for years and years and years. In the late 90s, there was a study about maintenance therapy, taxanes. What we haven't had until recently is a more tolerable maintenance therapy, something that patients can live their life without much side effects.
Right.
That's where bevacizumab came into play first as a maintenance therapy to help keep the disease away longer. And it worked. It didn't change survival, but it helped to keep the disease away longer. Now, another maintenance therapy is this PARP inhibitors, similar to what we've seen in the Athena trial, and in the Prima trial, and there's something called a Paola trial with actually we give bevacizumab and a PARP inhibitor, two maintenance therapies. There's also a trial called Solo-1 using olaparib in BRCA positive patients. So whatever the maintenance therapy is, it helps keep the disease away longer. BEV is a good option. The problem with BEV is it requires an infusion, so the patients need to come in once every 3 weeks. PARP inhibitors are a good option, which are a pill, but they still need to monitor their labs, and they're not without side effects.
So we talked a lot about BRCA-driven cancers, ovarian cancers, but just in general, if you had to just kind of summarize any advances happening in the platinum-resistant space, I know that there's a lot going on in the resistant space, which our overcomers are quite excited about. As you know, majority of our patients and overcomers are platinum-resistant. So what new advances or trials would you like to share with us when it comes to platinum-resistant ovarian cancer?
Yeah, so my answer is sort of mixed. Okay, so I'm so excited about the number of trials that we have. And we're investigating immunotherapy. We're investigating other biomarker-driven therapies that we're finding in ovarian cancer. We're using adenovirus, oncolytic virus vaccines. We're taking tumor out of the body, creating a vaccine and putting it back in. There's something called tumor treatment fields where we line the abdomen with radiation bands to help decrease the cancer. These are all things that we're investigating. But at the same time, they're difficult to come up with positive results. It was reported out a study by a company called VBL using their ovarian cancer drug was negative in the platinum-resistant setting. So as an investigator, as a team of investigators, we don't give up. We're not saying, well, we have a negative trial, we have to stop. It actually motivates to work harder to come up with a good treatment option for those women with platinum-resistant ovarian cancer. So it's frustrating, it's saddening. It makes some of us angry when we don't see a positive result, but it's not deterring us from our ultimate goal of coming up with a better therapy.
So the VBL trial that you're talking about, I'm assuming it's the Oval trial, right?
It's the Oval trial, and that's negative. Yeah.
So what if you could go into a little more detail on that? What were some of the things that did not work? Why didn't it work, you think?
Yes. So the way that's it had positive earlier data. The way that worked is it was a randomized phase 3 trial.
Mm-hmm.
So compared their agent versus standard chemo versus our standard treatment, which is weekly paclitaxel and bevacizumab. Now the problem was the control arm did very well. Mm-hmm. Patients who received the standard of care did very well. So the results here, I'm just looking at the results. The progression-free survival in the treatment arm, it's called Ovar, their drug and paclitaxel had a progression-free survival of 5.29 months. The control arm of paclitaxel, 5.36 months. Mm. So it was a couple of days actually better. So the good news is our current standards, sort of the best. We've been treating people correctly, but obviously the bad news is we're not making progress, and we desperately need to make more progress in this setting.
Yeah, but as you said, there are so many trials open in platinum resistant, and we know that our overcomers are all excited to learn and know more about the advances happening in this space. So we are just praying and wishing and hoping that something works, or not just something. There are few options for our platinum resistant patients that would be truly game changing for our community. So thank you for keeping us up.
And through the GOG, the largest area that we are investigating is platinum-resistant setting. What I'd encourage the patients who suffer from this is to try to find a clinical trial.
Yes.
Because I think ultimately clinical trials are the best way to treat cancers.
One thing I will ask you, Dr. Slomovitz, on behalf of our patients, because we do get this question from our overcomers, that yes, clinical trials are fantastic, and that is what is going to, kind of push the research and the advances in ovarian cancer. However, when things like these fail, when clinical trials fail, right? Like we talked about the Oval trial, what is the implication for the overcomer and the family members that they should know of? Because, as a family member or a patient, you sign up on a clinical trial with a lot of hope, and there's not just the clinical aspect, there's an emotional and hope aspect to it as well, right? When that fails, then how is that managed when it comes to the patients? What should our overcomers know about that? The reason I'm asking is because when we talk about clinical trials, that is one of the most talked about concerns that come up on the surface, that what if it doesn't work? What happens?
Right. The first thing I want to highlight, and that's an excellent question. The first thing I want to highlight is these aren't drug versus placebo. Mm-hmm. These are trials that patients get the experimental drug and they compare it to the standard of care. Now, as I mentioned with the Oval results, the treatment we were giving was not detrimental.
Right.
It wasn't portending a worse prognosis. It was equivalent. Yeah. So all it said is, why give a patient a new drug that works the same as the current standard of paclitaxel? And we monitor these trials very closely. If there's a signal that it's going to really be worse, then we stop it.
Mm-hmm.
So what I tell my patients who are involved with clinical trials that that the trial's negative, don't give up. Right. Number one, they still got the best treatments, the best standard of care, and there's always other options. I remember vividly before practicing here in Miami Beach, I practiced up in New Jersey, and I had a patient who, with platinum sensitive ovarian cancer, she recurred, 6 or 8 months after treatment. We put her on a trial, looking at a trial with the alpha folate receptor, and she started the trial, and she's like cruising along on the trial. During the trial, the results came, while she was on it, the results came out. It was a negative trial.
Mm-hmm.
But the trial allowed those patients who are doing well to continue.
Okay.
Now, this is a woman with advanced stage ovarian cancer. That was about 12 years ago. And she has no evidence of disease.
Oh my God.
So just because the trial could be negative, it doesn't mean it has a negative impact on the individual.
Thank you so very much for sharing. Yes, thank you so very much for sharing that, because this is significant information that, I think all of us need to understand and know better when we are signing up for clinical trials, because this is one of the concerns that we get repeatedly talked about by the overcomers. So thank you so very much for especially this example. I know that this will help our community a lot. So thank you.
Not only is she a great patient, she's a friend. I mean, she's one of my Facebook friends. She's doing phenomenally well, and we're both Bruce Springsteen fans, so it's pretty fun to chat with her.
That's wonderful. So just not a very clinical question, but if it's just a question that I thought you would do justice to. So if you could change the tomorrow for our overcomers, how and what would you do to do that?
Yeah, what I do is I remind people, first of all, 10, 15 years ago, my waiting room was filled with 3-year survivors. Yeah. Right. And then 8 to 10 years, 7 to 10 years, they're filled with 5-year survivors. And then, this 5 years ago, filled with like 8-year survivors. 2022, and this is not for everyone, but I have a waiting room sometimes of 10, 12-year survivors. So, if we could change, if we could look back and see that, what I always tell people is, someone who may be 3 years out or 4 years out who's doing great, I say, well, we have 10-year survivors. Then they look at their calendar. Oh, when am I going to die in 7 years? No, that's not the case. The progress we're making, so over that next 7 years, we can make more and more progress to get 15 and 20-year survivors.
Exactly.
So the future should be in patients doing well. No one could put themselves in their shoes. No one, not their husbands, not their partners, not their family, but in the patients that are doing well, there's the future could be bright. Again, not for everyone, but the future could be right as far as coming up with new treatment options and getting new treatments to our patients, maintaining or improving the quality of life, patient-reported outcomes, and things like that. But that's what I hope for tomorrow. Keep pushing the envelope.
That's a wonderful answer. Thank you so much, Dr. Slomovitz. And just in closing, I would ask you, what message of overcoming would you like to share with all our overcomers listening?
Yeah, no. Well, again, thank you very much for having me here. I think it's your group, your audience, they're very, very, very strong. They want to do what's best for themselves. They one of the reasons why I went to gynecologic oncology is women are better patients than men. I'll say it here in front of you.
We are better overall anyways, not just as patients.
Oh, not only patients, exactly. And particularly I'll be careful of the answer, but particularly in healthcare, women care about prevention. Women care about their health. Women, oftentimes a woman with ovarian cancer will come in and say, I went to the doctor 2 months ago and nothing was wrong. So they're really their best advocates. And I could see in your group, you're getting that same group of individuals. Getting ovarian cancer, while some of it's hereditary, most of it's bad luck. And maybe there's a higher reason for some of these stronger individuals to get it, to show that they're a fighter, to show that they could deal with rough times, to get through them. to show their strength to their family and their friends and their loved ones. And we pray for them to do well. All right. We work tireless. I was just in an ovarian cancer meeting in Chicago for the last 5 days, and we were going nonstop from Tuesday night when I landed. Meetings till 9, 10 o'clock. Next day, 7 a.m. to 9 o'clock again. We were going nonstop. One night we went out to dinner with friends, but that's important too, to talk about ideas and to work on the networking. But really nonstop, and we're not going to stop until we get 100% survival. We got a ways to go, but we're making slow and steady improvements. So I would tell your audience, be positive, be strong. I also tell people, all of us, you, me, we're all going to die one day. And we're all going to look at today and we're going to say, today was a good day.
Exactly.
All right. So, today's a good day. Don't lie in bed if you're tired. Get out of bed and go for a walk. Go to the movies. COVID's almost over. Go to the movies. Go to the restaurants. Walk around the park. Things like that. But be positive. Be strong.
Thank you, Dr. Slomovitz. This was wonderful. Your vision, your clinical expertise is extraordinary, but your vision for a world without ovarian cancer and all things that you shared for our overcomers, your encouragement, we really appreciate you for that. And we know that you and your fellow, doctors, you are nonstop and you're doing so much for our community. So we are grateful and thankful to all of you for all the great work that you do to end ovarian cancer for all of us one day. So thank you so very much for this thoughtful conversation and for sharing all these great insights with us. We are appreciative of you and your time, and overcomers hope this was beneficial for you. I know that this was greatly beneficial for me as I talked to Dr. Slomovitz about all the recent advances, and not only that, just to hear his own passion and his commitment to our overcomers, which was phenomenal. So please share this video far and wide with anyone who may benefit from all this information, and we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.
Thank you very much.